Everyone say good morning. Well, it's lovely to be here today amongst friends, and I just want to know if I got any new friends. Anyone new here today? Anyone? Hands up if you're brand new. Welcome. Let's give all the newies a round of applause. They've done very well to get here on time. Thank you very much. And yes, apologies for the delay. We were just having a few technical difficulties, and also the wardrobe change had to happen as well. So thank you for your patience. We'll make it up at morning tea and lunch, all right? We promise. So it's really great to be here today, and welcome to the New Zealand Respiratory Conference. It's great to be here, and I reckon you need to give yourselves another round of applause for actually surviving the evening and getting here this morning at all. So give yourselves a big clap. It was a very good function last night. How amazing were those kids from Ranui Primary, eh? So incredible, such great talent we've got. It gave me such hope for the world that we had such talented people in our presence. So it's great to know that we have that happening. Well, we have got a jam-packed day today, and I'm very excited to be sharing everything that's going on right now. So just for everyone who's brand new, there's a couple of housekeeping things I'm going to redo again for your benefit especially. But what we need to do is just know that in case of emergency, today our Pullman staff will help us. All we need to do is just head out those main doors there, or those doors there, turn left and go to the Omnibar. Everyone say Omnibar. You're wonderful. If we're downstairs, there are exits to the left in the lovely networking hub downstairs as well, so we can hop out that way if we need to as well. Mobile phones, get your phone out right now. If you wouldn't mind just turning it to silent, that would be fantastic. And again, if you do need to social media, I should say, through the conference, that's great, do that. But do use the hashtag NZRC. That would be great, because that's our hashtag for the conference. And anything, any photos, any thoughts, feedback, comments, highlights, if you put that little hashtag with it on Facebook or on Twitter or even on Instagram, we all get to see those if we search for that. So that's very exciting. The other thing is too, what do I need to talk about? So downstairs, we've got 4 small flights of stairs that we go down to. Downstairs, that's our networking hub, as everyone yesterday will remember. That's where we have morning tea, lunch, afternoon tea, and all coffees. And our wonderful sponsors are down there, and our service providers are there who would love to meet you if you haven't met them already. What else do I need to tell you? If you require a certificate of attendance, that's in your pack already. If you need a CME certificate, there's a little form you can fill out there to help get you your accredited hours for attendance at the conference. So fill out the form at the registration desk and you can get that certificate sorted out. Right, well, today we've got all sorts of things going on, and we have Breathless TV coming back today. We've got... I have it on good authority that some of the prizes today are worth $100. Everyone say, ooh. So there may be a couple of things we need to do in order to win those prizes, but I'm excited to be on the couch with Erin Simpson presenting at Breathless TV and giving away a whole bunch of prizes, because it's all about fun today. We've got to make sure we try and stick to time a little bit today, so I will come downstairs and let everyone know we've got about 5 minutes to get back. If you could just finish up your conversation quickly and come back up, that will help us keep to time today. And also, during our awesome plenary speakers, at the end of some of those, we will have the opportunity to have question and answers as well. So do write down any questions you might have for our speakers, and then we might be able to ask them. We've got, excuse me, mic runners who are going to come around with microphones. Just say where you're from and what your name is, and so we can get to know you and then ask you a question, and we're away laughing. What else have we got? Did anyone get a chance to see the incredible graphic illustrated slides and the posters yesterday? How cool are they? Should we give them a nice clap, because they have done such a great job. Linda and Mary today, and all of their work. So some people were worried that yesterday that was going to be the only chance you were going to get to see their work. No. We are going to give you all of their slides and pictures of their posters at the end of the conference. So what's going to happen, in fact, all our speakers have been videoed, and in about a week or so, you'll get an email letting you know where you can find all the videos and also all of the pictures of the slides. So all of that is for you, and we're doing it for you to share with you in about a week or so. So you'll get that email. That's when you'll know it's happening. What else have we got? I've got to get through a couple of things too. Oh, and I just want to say a big thank you to everyone who came up to me yesterday and talked to me about Sailor the Pufferfish. Now, Sailor the Pufferfish is my good friend. There he is. We were the poster boys for the winter edition of this magazine right here. And Sailor the Pufferfish and I, we go into schools and we talk to children about asthma and how to manage their asthma a lot more effectively. And it's really great. We know the show really works. I had great fun sharing with Teresa earlier this year. We went and did a show at a school, and then a week later they had a full ambulance call out for an asthma emergency, and they wrote in to tell us specifically that they knew exactly what they could do to help the person that was in trouble. And so we know that is a really effective way of reaching younger audiences. So thank you to all the people that came and talked to me about Sailor. We would love to get him more around the country, wouldn't we, Teresa? That would be nice. He is the asthma champion of New Zealand, so that's very exciting. Right, I think we're ready to crack on with our first plenary for this morning, and we met this gentleman yesterday, but I'm going to give him a very large introduction because he has travelled a long way and deserves every minute of this. So this gentleman here is Dr. Stefano Del Giacco, and he is the Assistant Professor of Medicine and of Allergy and Clinical Immunology at the University of Cagliari in Sardinia, Italy, where he received his MD, and he is now the head of Asthma and Allergy of the Asthma and Allergy Unit at the University Hospital. His research interests range in the fields of asthma, allergy, and autoimmune diseases, with a particular focus on psychological aspects of asthma, asthma and allergy in sports practice, and on the role of allergy in asthma. He has been a member of the European Academy of Allergy and Clinical Immunology since 1995, where he chaired the interest group on allergy, asthma and sports, and was the secretary to the asthma section from 2007 to 2012. Would you please give a huge welcome to Dr. Stefano?
Well, good morning, everyone. Thanks, Chris. And again, many thanks to the Asthma Foundation and Allergy New Zealand for inviting me here. It's a great pleasure to be here today. And I will have two talks, as Chris told you. The first one is related to the work of our task force within the European Academy of Allergy and Clinical Immunology, and it's related to the role of allergy in severe asthma. Allergy has been for many times, for a long time, thought to be responsible of asthma, but is asthma an allergic disease? This is the question that for a long time experts were asking all over the world, and we try to somehow clarify the real role of allergy, in particular in the severe asthma form. So first of all, we have to define the severe asthma. The definition that is currently used is the one that has been made by European Respiratory Society and American Thoracic Society. That is asthma, which requires treatment with guidelines suggesting medication for GINA steps 4 and 5. So the highest dose of medications, and but is uncontrolled with poor symptom control, with the ACQ consistently over 1.5, ACT minus than 20, and frequent severe exacerbation, at least one hospitalization. So several factors that define clearly what is severe asthma today. And it's known that allergic sensitization is a strong risk factor for asthma in childhood and adulthood. And so, as I told you, the European Academy of Allergy and Clinical Immunology decided to put on a task force in order to understand the real role of allergy in severe asthma. So already in this old paper in 2001, the group of Simpson and Kustovic were showing how in a multivariate regression analysis, sensitization to several allergens were all independently associated with asthma. And odds ratio for current asthma increased with increasing number of positive skin tests. So the more skin tests you have positive, the more is the risk for current asthma. And also dog ownership and current smoking, of course, were significantly associated with asthma ever. So already 15 years ago, we got to know that allergy played a clear role in asthma. And there are many papers that are trying to clarify this. For instance, this is in Ghana, and house dust mite sensitization and cockroach allergen sensitization in children were independent risk factors for asthma in urban Ghana. And also, another task force from IACI, from a similar group, were trying to clarify the type of severe asthma. And type of severe asthma, we see that we have severe atopic form, severe intrinsic asthma, severe asthma with obesity, and sudden asthma attacks. But we are interested in this one, severe atopic form, where patients show high serum IgE levels, detectable allergen-specific IgEs, and frequently presenting with fungal sensitivity, predominantly to Aspergillosis. And also, in the study, the identification of asthma phenotypes, we already saw yesterday that we have different phenotypes of asthma, each one of which is due to probably different causes. And in this study, they were showing that cluster 1, cluster 2, cluster 4, they were all related to atopy. Mild atopic asthma, mild moderate atopic asthma, severe atopic asthma, while only 2 clusters were not related to atopy. So, as you know, atopy is somehow the risk of developing allergy. And this is important to underline, because sometimes we see patients that they come to us and say, hey doctor, I want to know if I am allergic. But this makes no sense. I mean, because either you have clinical symptoms, otherwise it makes no sense to check if you are allergic, because you can be sensitized, meaning that you are positive to skin prick testing, but you can be not allergic, meaning that you have no clinical symptoms. So, allergic asthma is characterized by symptoms upon unequivocal exposure to the allergens resulted positive to skin prick testing or specific IgE. So, once you undergo prick testing, you must, your doctor or your nurse must understand which of the positive skin prick testing are linked to your clinical symptoms and which are not. This is also important for specific immunotherapy in terms of future directions for curing the patient's allergy. And evidence of early sensitization in preschool children, we saw yesterday that we have a kind of preschool asthma, is the main predictor of asthma development by school age. So also these studies on Lancet were demonstrating that sensitization in early life can be a predictor of asthma by school age. And this graph shows a highly significant increase in the risk of hospital admission after age 3 only among children in one of the atopy subgroups, but not other atopic classes. So we can see here that we have atopic vulnerability, multiple early. So the ones that were being sensitized before age 3, they were at high risk for hospital admission for with asthma, with a highly significantly fashion. This is related to also to multiple early children, but when they had sensitization after age 3. And quantification of atopy is important. So it depends on the SPT size, so the skin prick testing size, the diameter of the wheel, is important and is independently associated to lung function and airway hyperresponsiveness. And the summative size of SPT wheals looks to be a better predictor of the onset, presence, persistent, and severity of childhood asthma than the mere presence of a positive allergy test, meaning that you not only have to calculate if you're positive to see if you're positive to a skin prick testing, but the sum of them can be a predictor. And so quantification of atopy sensitization in early life can be a discriminator to identify in early life who is at risk of severe and persistent asthma. Specific IgE and skin prick testing are complementary. So we should consider both, and a paper from Kustovic and collaborators were showing that also specific IgG, but not IgG4 antibodies, modify the association between specific IgE and wheezing, with the risk of symptom decreasing with increasing IgG levels. So IgG levels seems to be protective, but it's not clear the mechanism yet. And also, we have links between sensitization and the so-called back-to-school asthma. The back-to-school asthma is the one that children get when they go back to school. In fact, after holidays, they go back to school and they are in community with other children, and so they get virus infections, and so they have this kind of exacerbations. And there's a strong interaction between the levels of specific IgE to inhalants and respiratory virus infections in increasing the risk of hospital admission. So this kind of asthma must be prevented in a way, and some study, omalizumab, reducing the back-to-school asthma exacerbation, indirectly confirming a synergism between quantitative sensitization and respiratory viral infections. Also here, in these papers, we have a demonstration that the size of skin prick testing wheels to inhalants and counts in terms of predicting the severe treatment-resistant asthma, so the kind of asthma that is refractory somehow to several treatments. And so it's characterized by large size of SPT wheels, both to inhalants and food allergens. But in this case, specific IgE and skin prick testing are not always concordant, so you need to carry out both tests in this kind of patients. If you have a patient that does not respond to treatments, probably he has a severe treatment-resistant asthma, and you must carry out both tests to clarify this. And furthermore, we have the so-called adult-onset asthma, where we have eosinophilia, that is a characteristic of allergic asthma somehow, but without overt evidence of allergy. And so probably there is a role for innate immunity, for epithelial innate cytokines that directly induce the recruitment of lymphoid cells that secrete Th2 cytokines, but without generation of IgE. So it's a kind of allergic asthma that is non-allergic. And they will probably respond very well to, for instance, mepolizumab, an anti-IL-5 new biological drugs, and without being allergic. So we must consider also this, that not always the positivity to skin prick testing or to specific IgE identifies a kind of allergic asthma, but can be also something of this kind with eosinophilia without overt evidence of allergy. So role for some cytokines in this special type of asthma, and anyway, allergy probably plays still a central role in this phenotype. And now let's talk about the crosstalk between environmental factors, allergic sensitization, and asthma. So it's now very clear that viral infections and allergic hyperinflammation have a synergistic effect in asthma. And the lower respiratory tract infections and atopy or sensitization, they contribute to asthma development exacerbation, as we already saw in the previous slides. In this paper, there is, you see, a bidirectional link between viral infection and allergic inflammation, and this starts to confirm that probably the role of allergy is not alone in inducing severe asthma, but probably it needs cofactors to develop this kind of severe asthma. There are several factors. It is very technical stuff, but this is the message somehow. And other evidences for a higher risk of asthma in viral infections. So the type of virus, if you have a rhinovirus infections, you have a 10-fold risk of developing asthma, and 5-fold with respiratory syncytial virus. And all these are evidences for a higher risk of asthma. So the severity of lower respiratory tract infection, the age, atopic predisposition, number of episodes during the first life predict a more severe form of asthma, and probably due to a less efficacious immune response to rhinovirus C. Regarding fungi, we were talking yesterday about fungi, and surprisingly, at least to me, when I was checking the data, I saw that 6.5 million people have severe asthma with fungal sensitization. And up to 50% of adults attending secondary care have fungal sensitization, and probably an estimate of 4.8 million adults have allergic bronchopulmonary aspergillosis. And it has been demonstrated that fungal allergy drives asthma severity. And this is a special, somehow, issue because in contrast to other sensitizers, antifungal therapy is available. So we can not only cure the symptoms, but we also can cure the cause. This is another task force from Giacchi. We worked on this, and we were somehow trying to clarify the humans-fungi interactions. We have 3 levels of interaction between humans and fungi. The first one is the fungal sensitization. So you are sensitized, you are positive to skin prick testing or specific IgE, and that's a kind of allergy to fungi. So this is positive to skin prick testing, so sensitization. Then you have allergy, so with symptoms and colonization. So this one, the last one, is the worst one, of course, because you have lung colonization by fungi, and specific diseases related to these levels of interaction are allergic bronchopulmonary aspergillosis, allergic bronchopulmonary mycosis when another fungus is involved, not Aspergillus, and severe asthma with fungal sensitization. The main difference between the different fungi is that we have a group of fungi that do not grow at body temperature and another group that grow at body temperature. And so the outcome for these two groups is different because the fungi that do not grow at body temperature are considered as aeroallergens. So they give allergy, they can cause allergy. Typically they are Cladosporium, Alternaria, or some mycotoxins. And these all can only cause allergy. Fungi that grow at body temperature are so-called pathogens, and they can cause both infection and or allergy. Yeasts, Aspergillus, and Penicillium. So they can colonize and give much worse disease. These are the disease, the chronic pulmonary aspergillosis, invasive aspergillosis, of course, allergic bronchopulmonary aspergillosis, allergic bronchopulmonary mycosis, but we want to focus today on severe asthma with fungal sensitization. The difference between allergic bronchopulmonary aspergillosis and severe asthma with fungal sensitization is that I can make it, yeah. So ABPA has elevated total serum IgE, so more than 1,000, and patients should have Aspergillus fumigatus skin test positive or elevated Aspergillus fumigatus IgE levels, total serum IgE, and positive IgG or radiographic patterns that are somehow consistent with allergic bronchopulmonary aspergillosis. And they should have eosinophil count more than 500 cells. The definition of severe asthma with fungal sensitization that our task force gave instead is severe asthma, of course, so you must have severe asthma, as we saw in the first slide with the definition, with the current definition of severe asthma. One of this kind of asthma somehow, but with total IgE less than 1,000. Severe asthma, of course, and sensitization to any fungus by skin prick test or specific IgE. So very simple. So the difference is in the number of total IgE, in the positivity of specific IgE, and in the sensitization to any fungus. So if you are sensitized to any fungus, if your total IgE are less than 1,000 and you have severe asthma, probably you have severe asthma with fungal sensitization. So there are many studies in this field, and this meta-analysis by Zurich and collaborators were showing that the increasing frequency of fungal skin test positivity in severe asthma and the relative odds ratio, yesterday already Professor Dawes were telling you what an odds ratio is, somehow the risk of developing a disease in this case. So the odds ratio is 2.56, so 2.56 fold time the risk of having severe asthma in people sensitized to fungi, as we can see. Okay, we don't stay on this one, but the pathogenesis, of course, you see genetic. Always there is something related to genetic. David, he knows very well. So anyway, there are several factors you can check, but theories are still going on. But probably the more is high the Th2 response, the more is severe the fungus disease. And so you see the different levels of fungus disease. The screening tests for fungi-associated conditions are the one you know very well, skin prick testing. You can use intradermal tests even if they are rarely used. The Immunocap IgE, complete blood count for checking eosinophils, and you can also perform fungal culture of sputum or PCR on sputum. So you have different armamentarium for checking the fungi-associated conditions. As all the algorithms, this is complicated, but anyway, you have to start. First of all, your patient should have bronchial asthma. Then, if a skin test is positive and specific IgE levels are elevated, you must check the level, and then you go to the right or to the left, depending on the level of IgE. For sure, high resolution CT scan is important in order to check opacities, pulmonary opacities, and other problems. And then you get to a different diagnosis. Now some words on occupational asthma. Occupational asthma is thought to be something that only happens at work. If you are a worker in an industry or with chemicals, for sure you can have occupational asthma, but also a farmer and other jobs. But probably not all know that 90% of occupational asthma is of allergic origin. And so the work-related asthma also follows a clear protocol to understand the role of allergy in occupational asthma. And there are two big groups in occupational asthma, the occupational asthma itself and the work-exacerbated asthma. So it's the work-exacerbated asthma is the one that worsens at work. So when you go to work, you get maybe an allergen that can exacerbate your asthma, your already existing asthma, while if your asthma is caused by work, you have a real occupational asthma, so you have to check if it's non-allergic, so due to irritants, or is an allergic form, IgE dependent or non-IgE dependent. So also this must be considered when checking the role of allergy in severe asthma. And yesterday, some speakers talked about pollution, and the role of pollutants is really important in severe asthma. So we were talking about cofactors in severe asthma, and for sure pollutants are important cofactors in severe asthma. So nitrogen dioxide can cause different outcomes on respiratory, on the airways somehow. So decreased FEV1, less growth of FEV1 over time, lower measures of FVC. And also other pollutants like PM2.5, PM10 can cause alterations on the respiratory function, as well as ozone or ultrafine carbon black particles that can also influence, for instance, immune cells. They induce maturation of the dendritic cells in vivo. So this must be considered. And also there is a direct effect on allergic inflammation. We saw this one, but also the diesel exhaust particles. So the pollution that comes by car and trucks mainly, or motors used for heating or other kind of diesel-powered motors can increase IgE, can cause an accumulation of allergen-specific Th2, Th17 cells in the lungs, so causing local immune reactions in the lungs, and can also activate different cells, Th2 and ILC2, that can contribute in airway inflammation related to diesel exhaust particles. So this is very important. So we saw that we have several cofactors that interact with allergy. So probably allergy itself alone is not able to cause severe asthma in most of the patients, but for sure it's the main problem that is linked to other cofactors that can cause a worse outcome. And this is interesting. This is an Italian group that was trying to measure the levels of salbutamol in the wastewater of Milan. And so they were measuring this in comparison to the days of pollution. And you see, this is the link. So this is PM10 levels. This is pollution levels somehow here, and the use of salbutamol. And you see that significantly, the use of salbutamol was higher when pollution was higher. So this is clear. This is a clear message that pollution can increase the risk of asthma, it can increase severity. So this is a very interesting study. It's a 2006 paper. Then some words about smoking. Smoking for sure can cause, everybody knows, is not good for asthma, but surprisingly many asthmatics are smokers, actually. But how can smoke influence the severity of asthma? It can influence severity of asthma with developing corticosteroid resistance, so the patient is trying to use his inhaler, but no effect somehow, and then increase the sensitization to some allergens, and so together the interaction between smoking and allergy can cause a much worse outcome of asthma, so causing then a higher risk for severe asthma. Jerome was showing this yesterday, and this is interesting because thunderstorms can somehow change, open the pollens somehow or other allergens, and so they can spread the allergens in the air and causing exacerbations, sudden exacerbation of asthma. And these are several studies that this paper examined in which there was an outbreak of exacerbation related to thunderstorm. So going to the take-home messages of my first presentation. So there is an increasing evidence about an important role for allergy in severe asthma. The role is not exclusive, so we need cofactors. And in children, in particular, with early allergic sensitization, allergy plays a fundamental role, but in adults, the role is still under discussion, role of pollution, and for sure other cofactors that we still don't know must be completely and efficaciously uncovered. Okay, thank you. This is the first one. And should I switch to the next one? Okay. Okay, now we'll talk about psychological and social effects of asthma. Our group has been working on this for a long time, but the literature is quite rich in this field. And the overview of my presentation is, we'll talk about some history, overview of the current literature, how can psychopathology affect asthma, our research on asthma and psychiatric disorder, and take-home messages. So I'm not telling you anything very new because the psychological effects of asthma were known since 1,000 years ago, when Moses Maimonides, in his treatise on asthma, was describing asthma as a difficulty of breathing or pain in the chest, suggesting behavioral changes as one of the cure. And more recently, Sir William Osler was saying that all authors agree that there is in a majority of cases of bronchial asthma a strong neurotic element advocating relaxation techniques. But even more recently, between the 30s and the 50s, asthma has been considered one of the Holy Seven psychosomatic illnesses. And Helen Flanders Dunbar, that was one of the queens of psychosomatic medicine, was describing asthma as a psychosomatic disease with treatment firstly involving psychoanalysis or talking cures. And why this is important? Because we were thinking that in the past decades, hospital care for asthma decreased, luckily, mortality for asthma decreased. Finally, we have new drugs, because until the 90s, we had no new drugs for asthma somehow, so it's one of the diseases for which less new drugs have been invented, but non-controlled asthma and severe asthma are on the rise, and poorly controlled asthma is on the rise. So this is frustrating because there is should be something wrong there, because we don't have an answer. Which are the causes? Probably a long list of causes, lack of access to asthma clinics and medication, under treatment, poor perception of asthma, phenotypes, endotypes, role of allergy, remodeling of the airways, physician-diagnosed asthma that sometimes cannot be verified, different outcomes in asthma studies in comparison to real life, because you know that very often in asthma studies the population is very well selected. They must be blonde between 30 and 40 years, and they must not have diabetes, and so the real life is not there. They must not be overweight, and this is not the real life, we know very well. And so we thought that emotional factors are probably one of the obstacles in the diagnosis and treatment of asthma. Asthma is linked to psychiatric disorders. We checked Medline, as everybody does, more than 1,000 articles, ranging from 31-38% of psychiatric disorders in asthmatic patients. Between 13 and 38% reports of anxiety, and between 6 and 27% reports of panic attacks in asthmatic. Correlation between asthma and psychiatric disorders. Improvement of respiratory symptoms curing psychiatric disorders, and correct treatment for psychopathology was improving the respiratory symptom in asthmatics. But we must be aware that some asthma symptoms are probably not only asthma symptoms, because if from the one side we have inflammation, airway hyperresponsiveness, and reversible airway obstruction that are evidence-based symptoms that we measure with spirometry or methacholine or bronchoprovocation test or checking the cellularity in the sputum, but there are some symptoms that are not evidence-based, like episodic breathlessness, wheeze, cough, tightness of chest, shortness of breath. So these symptoms are not only asthmatic symptoms, and we know this very well. And so we will see now an overview of the literature in this field. So the importance of depressed mood. In this study, there were the patients even with mild depressive symptoms have significantly more severe allergic complaints and assess general health state as much worse than those without depressive symptoms. You can see here, for instance, that allergic patients with a comorbidity in a psychological field, you see severe depression, they were complaining for very high allergic symptoms, moderate depression, and no depression. So we can see that it can influence for sure the outcome of the disease, and also here the severity of allergic complaints divided for type of allergy, type of disease, and this is, for instance, this is related to asthma. So the depressed asthma patients, the severely depressed asthma patient, they were complaining for more serious symptoms. This is another paper from a Brazilian group that was showing that controlled and uncontrolled asthma, the proportion of patients with psychiatric disorders between controlled and uncontrolled asthma. So the uncontrolled asthma was showing a much higher rate of psychiatric patients. And these are interesting studies that were performed checking the respiratory resistance in patients that underwent somehow unpleasant, neutral, and pleasant stimuli in terms of pictures and movies that were shown to them. And we see that the dark ones are patient treated with placebo, and the other one is treated with ipratropium. That is the medication, as you know, that is an anticholinergic drug. And so you can see that asthmatic patients, in the rows to the left, they have much higher symptoms, much higher resistance in the airways compared to non-asthmatic patients, of course, but compared to asthmatic patients with undergoing ipratropium treatment. So depending on the kind of stimulus, they were somehow having different outcomes, but somehow ipratropium was working. So probably the unpleasant stimuli can stimulate the cholinergic pathways. And so in this case, it's probably the use of an anticholinergic drug can be interesting. This is similar. You see film, picture, unpleasant stimuli, also another kind of measurement, but two different somehow measures of airway resistance, and also the use of ipratropium was decreasing somehow the resistance of the airways. And also here probably there is a vagal mechanism. So this is another study, similar studies, is quite complicated, but you see the vagal activation and sympathetic activation. That is in the yellow. It's non-depressed patients somehow, and you see that probably the vagal bias, the difference somehow in the vagal activation was probably responsible for increased airway resistance. Again, movies, a different visit, depressed in yellow, non-depressed. So they also have a difference in respiratory resistance with different stimulus. But then there are large epidemiological studies that sometimes, as all the large epidemiological studies, cannot be very representative of the real magnitude of the problem. So anyway, I think there were telephone interviews to a general population in Canada. But anyway, you see the odds ratio, the famous odds ratio, so the risk of having asthma of having a mental disorder was much higher in patients with asthma than in patients without asthma. So having asthma was increasing the risk of a mental disorder. And why this is important? It's important because there are in real life practical problems like increased healthcare utilization. This is, to me, shocking. For instance, patients, cases with psychopathology somehow, were going more than 4 times a year to their GP for an asthma visit, 71% of cases and 29% of non-cases. So patients both with asthma, but the first group is with psychopathology and the second one without. Chest physician, 81 and 77 is similar, but emergency visits, more than 2 last year, 71% in cases and 31% in non-cases. Exacerbations, 92.3%. So almost all the patients with psychopathology had more than 2 exacerbations last year in comparison to 56.9% of patients without any mental comorbidity. So this is quite shocking. Also in terms of hospital admissions, 90% against 5.2%. So this is clear, shows clearly that psychopathology can influence healthcare utilization. Okay, this is funny because anxiety and allergies. So some children were asked if they had allergies, somehow to self-report their allergies. And this is the outcome: no allergy, this is the percentage with self-reported allergies, 60% with no anxiety, almost 60 in a single episode anxiety. Recurrent anxiety, they were reporting more than 70% of allergies, self-reported. But then the same patients underwent skin prick testing to see if they were really allergic or not. And you see that are almost the same, the results are almost the same. In particular, recurrent anxiety patients had even a lower rate of real allergies than no anxiety patients. So their anxiety were bringing them to think that they were allergic. And these are also the level of total IG that is more than similar in the three groups. But look at this. So there are other factors, probably. This is more a curiosity than more something funny than a real thing. But two papers, one of which is a letter on Lancet, were showing that Facebook and social network can be, if overused somehow, a new trigger for asthma. So this was a patient that were having exacerbation all the time. He was checking Facebook. And this is an overview on social networks. So this can also be a modern factor for somehow severe asthma, a trigger for severe asthma. So other data of the real life. These are depressed patients, major depression, all the famous asthma symptoms, dyspnea, awakening at night, use of preventer medication, morning symptoms, days lost from work, hospitalization. And you see that in comparison to yes and no, so patient without depression, you see that the difference is really high. 34.2% of asthmatic patients with depression were waking up at night, in comparison to 11.5 that had no depression. Morning symptoms, 25 against 8%. Days lost, 19 against 13, while hospitalization were the same. So this is a clear sign that depression can strongly influence also the outcome of the very known symptoms of asthma. And this is also this is the same, I think, than before. Sorry about that, but no, okay, this one. This one is another meta-analysis that took into consideration the differences in asthma-related emergency department visit between asthma patients with or without a psychological, psychiatric comorbidity. And we see that the odds ratio is switched to the right, meaning that they have an increased rate of emergency visits for asthmatic patients with mental comorbidity. GP visits, again, somehow overpassing the previous paper, but this is a meta-analysis, so analyzes several papers with the same topic. Also, again, we see an increased risk, and also another paper showing that with the specific questionnaires, depression and anxiety were present in many asthmatic patients. This is my favorite, actually. Probably some of you know it, the roller coaster asthma. Roller coaster asthma was a nice experiment made by Rietveld, that is specialized in this kind of experiments, in which asthmatic women were invited, asthmatic and non-asthmatic women were invited to undergo a roller coaster ride. And also to fill in forms in which they were stating their dyspnea status. So at the intake, when they were invited to join, so dyspnea for asthmatic women was higher than controls. Right before starting the ride, dyspnea was exploding here, while it was slightly higher for controls. Right after, the dyspnea feeling was the same between the two groups. And next, the dyspnea feeling after some hours was clearly different between asthmatic and controls. But what they did, they measured lung function to see if dyspnea was real or not. Look at here. Asthmatic, control. Of course, controls had a better lung function. But before, the lung function was the same, was not raising. And after, was slightly lower, but then it was recovering. Now we compare the two tables. Look at here. Intake and real lung function. Okay, that's right. Before dyspnea feeling, lung function is exactly the same than at the intake. After, lower, and next. So this is a clear sign that dyspnea was self-perceived, but not a real lung function problem. And quickly we switch to alexithymia. Alexithymia is the impossibility of perceiving the signs of danger. And so it can make you brave, but it can also be a very big risk for asthma. And in the near fatal asthma, so the asthma that can bring you to death, the presence of alexithymia was an odds ratio, at an odds ratio of 2.175, meaning that doubled the risk of having a near fatal asthma. So patients with alexithymia, they are not able to recognize their symptoms, the symptoms of danger of an incoming asthma attack, and so they are at higher risk for a near fatal asthma. But I was liking this paper because it has your read Medline abstract with a pinch of salt. So not all we find on Medline, we must take it exactly as it is, because there are potential weaknesses of studies on asthma and psychiatric disorders. So non-validated questionnaires, telephone interviews. Are you anxious? Oh yes, I am. Because maybe today something happened wrong with a girlfriend or boyfriend, or postal questionnaires. Okay, let's fill in very quickly. I have to go to the supermarket. Self-reported symptoms. Have you dyspnea? Yes, but who tells you that is a true dyspnea or not? And retrospective studies in which directionality and causality of symptoms is not always possible, is not possible, I would say. So this brings to inaccurate diagnosis. And there are cofactors, very important cofactors in psychological and psychiatric problems. That is the BMI. So obesity brings to a higher risk of depression, anxiety, and other psychological problems. Marital status, divorced, not divorced, cohabiting, they all have different patterns of psychological problems. Education. Education also, there are differences between levels of education and psychological problems. Age, the more are you young, the less problems you have. And gender, unfortunately, females have a higher rate of psychological problems. Sorry. But this can be considered as methodological biases in the studies on that. Solutions is to perform a correct asthma diagnosis, so medical diagnosed asthma, matching cases and controls for confounding factors using validated questionnaire and face-to-face interviews. We must look at our patients personally to understand, not by phone or by postal questionnaire, to see if they really have psychological problems. And so in our study, we used the DSM, so that is the Diagnostic and Statistical Manual of Mental Disorders, with our colleagues from the psychiatry unit in Cagliari. And we were recently publishing this paper, the Asthma Anxiety Connection. It's a 2016 paper, just came out, in which we were studying a group, in fact, comparing the patients, matching the patients perfectly for their risk factors. So we tried to find the exact copy of the asthmatic patient into controls. And so we were studying them, we were matching them for education, you see, 72 females, 24 males, 8 primary school, 24 secondary school, 35 and 35 high school, university degree, 26 and 26, professional status. Unemployment, of course, is a risk factor for psychological problems. And especially, we matched them by BMI category in terms of overweight, normal weight, and obesity. And which were the results of our study? We are finding that lifetime anxiety was the only diagnosis that was showing a 3.03 odds ratio in asthmatic patients. So asthmatic patients had a threefold risk of developing lifetime anxiety. But luckily, we were not seeing any difference in terms of depression, for instance, mood disorders, lifetime mood disorders. There were no statistical differences, and only other minor current disorders were showing other statistical difference. So somehow, we demonstrated that asthma is associated with anxiety, but not with depression. And the question usually is, but asthma brings to anxiety, or anxiety brings to asthma? And so we also were checking this. We are checking this, demonstrating with a statistical significance that there is a bidirectional association between asthma and anxiety. So somehow asthma can predispose to lifetime anxiety, as well as lifetime anxiety can predispose to asthma. So these are the findings of our studies, but the next step will probably be investigating on how this happens. And so there are some cytokines that play an important role in inflammation in the brain and in the pathogenesis of depression. In fact, also in the psychiatric field, they are starting to wonder about new biological drugs, so drugs targeting directly cytokines to cure psychiatric problems. And we saw that some cytokines are in common. You see, TNF, IL-1, IL-6, they are in common between asthma and psychiatric disorders. So probably a common pathway in terms of immunological response in the complex psychoneuro endocrino-immunological network can be the answer to the bidirectional story of asthma and anxiety. And you probably heard about asthma endotypes. Endotypes are, we saw phenotypes, that is now quite clear that not all the asthma are the same, so phenotyping them in terms of cellularity or different clinical outcomes, but we also have endotypes. So probably within the same phenotype, there are different causes that can bring, as we saw before, for instance, for eosinophilia in adult-onset asthma, where in absence of allergy. And so probably we were wondering that at the moment comorbidities are not included in the phenotypes, but we were wondering that probably the asthma associated with psychopathology can be a new endotype, but this is, of course, pure speculation, because the pro-inflammatory cytokines play a role in psychiatric disorders, role of specific cytokines, and the common pathways. So, as a summary, with the take-home messages, we must always consider, so probably in our asthma clinic and in an asthma care plan, we should consider that asthma can be associated with psychopathology. So let's consider this, not only boosting medications if the patient is not responding, so not only increasing the levels of corticosteroids or finding new drugs and so on, but check maybe our patient is anxious, we cure his anxiety, and he can even decrease the levels of medications. We demonstrated that asthma is associated with anxiety, but not with depression, for which, of course, our study is a single study, so we can state that still a controversial association. And diagnostic and compliance issues. New endotype targeting cytokines may be with a common drug for asthma and psychiatric disorders. And so again, always check asthma patients for psychopathology. And I thank you very much.
We thank you so much, Doctor, and we have an opportunity now to ask questions about this presentation, which I found really fascinating. I wrote a whole page of notes, so I'm very excited to share those with you later on. But if anyone does have a question for Dr. Stefano, please put up your hand nice and high so that our mic runners can see you, because they've got to look from the back of the room. There we go. All right.
Thank you. Thank you very much for a really nice presentation. I really enjoyed that. For a lot of clinicians and a lot of people in this room, the difficulty is distinguishing between asthma, hyperventilation syndrome, and anxiety, because they all have very overlapping symptoms. And I don't know how many people in this room use the Nijmegen questionnaires, but you know, feeling of tightness in the chest and difficulty breathing are sort of part of the Nijmegen score. So just wonder if you have any comment about how we practically distinguish between these in clinical practice.
So a comment between distinguishing between?
Yeah, if you just, yeah.
Sorry, I don't know if the microphone was working when I started. So what I'm talking about is the overlap between asthma, which and anxiety, and of course they're associated, but then we've also got hyperventilation syndrome, which is associated with anxiety and has a very overlapping, also associated with asthma, and has a very overlapping sort of symptom profile. And I just wonder about practically how you recommend that we distinguish between them, or if you have any comment on that.
So to distinguish between anxiety and sorry, but the audio,
if you just speak a little slower and a little clearer, we will
Okay.
get that golden question. Sorry,
I'll try and be slow and clear.
The difference between what?
You've talked a lot about asthma, and there certainly is an overlap with anxiety, but
Yes.
there is an alternative diagnosis, which is hyperventilation syndrome.
Ah, okay.
Yeah, and I'm just it's really difficult to tease that out sometimes, and I just wonder if you had any comments on that.
Yeah, okay, thank you. Yes, there are there are some questionnaires on dysfunctional breathing and or hyperventilation. So you can use them, for instance, or otherwise you can surely you should the patient to have a clear psychiatric diagnosis should undergo a psychiatric interview with it's called a SHID-1 and a SHID-2. There are two questionnaires that are quite long. Or otherwise, it depends what you want to check. If you want to check alexithymia, for instance, you can check with the Toronto Alexithymia Scale. There are several questionnaires dedicated to different psychiatric disorders, but dysfunctional breathing has proper questionnaires to use, so you can maybe try to use one of them.
Another question?
I've got a question relating to your first presentation.
Yes.
You're talking about the importance of characterizing people's allergies and sensitivities. aside from fungal sensitivity, if you discover that people have sensitivity to various grasses, things like that, what are you actually doing with that information? Are you advocating for immunotherapy in severe asthma? Or are you using it just as part of understanding their presentation?
Well, immunotherapy, immunotherapy, it's good, it works very well for rhinitis, that of course you must consider as allergic rhinitis and its impact on asthma. It's very important to treat rhinitis in asthma patients, of course, in allergic asthma patients. So often you have multiple sensitizations, and this can make the thing confused. And I would try to check which one is linked to the clinical symptoms. And in my practical practice, I find the one that is mainly represented in connection with the clinical symptoms, and I give immunotherapy for that. If there are more than one, I don't prescribe immunotherapy because somebody prescribes with a double immunotherapy, but at least in Italy this is not very well recommended, and so I try to find the main one.
Any other questions today? Oh yes, one over there.
Hi, Rebecca Silverdale, which is North Auckland. Just wanting to clarify a point from your first presentation, thank you very much. When you were saying that skin prick test size was independently associated with risk of severe asthma in children and adults, just wondering if that was for true allergy, so symptom verified skin prick testing, or was that just they're sensitised? So is it true allergy versus sensitisation with the relationship, please?
Well, she asked if
yeah, if you could simplify that one. So it's very hard to hear out here. You're doing very well. Just if you could shorten that one a little bit.
Because the speakers are pointed to the
to you,
room.
we can't hear.
One of the points you made was that skin prick testing size was independently associated with severe asthma in children and adults. I was just wondering if that was just referring to sensitisation or whether that had been verified as true allergy with symptoms.
Okay. Well, the size is referred to sensitization. I mean, to both sensitization and allergy. So the summative size of SPT wheels is linked to the severity, but even of the ones that you don't think that they are linked to a clinical symptoms. So the total summative size.
Oh, one more question down here. Here comes Teresa.
I was just wondering if any of your studies have included ethnicity as perhaps something that can be related to.
That's an interesting question. Actually, in Italy and in my place, we have not that big differences. I mean, Caucasians are like 99.2% of people, so we were not differentiating it in terms of ethnicity. But this is for sure, it's a fantastic point to check, especially in places in which ethnicity, like here, is a real fact. Also, in the largest city, probably there maybe ethnicity changes a bit, but more than 95-97% will be always Caucasian in Italy. So, but this is, thank you, this is an interesting issue. We can maybe do something.
Yeah, I understand now why it wasn't on your list.
I have a question. I'm curious to know how you think our two countries, our two nations, compare in the way that they approach asthma and allergy treatment, and whether or not you think there's something that Italy could improve on, or whether or not there's something New Zealand could improve on from your experience.
This is a good question, thank you. Well, in Italy, we traditionally have an approach in terms of allergy always. I mean, we start, also the lung doctors, they immediately check for allergy, and I'm not exactly sure what you do here, but, and also we use a lot immunotherapy. I'm not sure you use it that much here. No, but we also use very often immunotherapy when needed, of course, and with the specification I told you, but this is an approach that we try to change the natural course of the disease, also because immunotherapy is the only thing that the World Health Organization say that can change the course of allergy. Otherwise, you must go on with medications. So probably this is the main difference. For the rest, as I had to notice downstairs yesterday, I see that medications and drugs and systems are almost the same, with difference in names, in commercial names. But so I think that we have quite similar approaches.
So we're doing okay. One more question here. We've got time for one more. Our mic runners are coming to you right now. That's good.
Just picking up on your comment about immunotherapy, is there a trend towards considering immunotherapy as early intervention? In other words, looking at it in children and potentially to reduce the trend, the potential severity of asthma in the future?
Well, we recommend actually immunotherapy since early life, since early ages. I mean, we usually give immunotherapy to patients that are 4, 5 years old. And there are studies on rhinitis, actually. I'm not aware about studies on changing the course of asthma, but for sure we give immunotherapy at all ages anyway. Also, since there is an outbreak of late onset allergies, so we more and more see patients that are like 60 or 65 that comes to us with allergies that till that time were not symptomatic. We also prescribe immunotherapy to them. So
right across the board there. I've got one last question for you. You are going to be in New Zealand for, until I think December 22nd. And
yes.
I'm just curious to know, number one, what are you looking forward to doing here? And number two, what have you really enjoyed so far?
Well, so far I enjoyed the friendly people, actually. Not because you're here, but because we had time for short walks downtown, but people is really friendly, and as I told you yesterday, we really feel home here probably because it's an island and we come from an island, so the spirit of people living on an island is slightly different. So, but anyway, the thing we most appreciated, and we are looking for the fantastic scenarios we were checking on the web for days and days, and fantastic nature, sports, tramping, you say, I think. It's like
tramping, yes. It's like tramping? That's America. Tramping, yes. Lots of tramping. Yes, and no plans to jump off the sky tower on the bungee cord?
We were seeing it, and why not?
Oh, okay. Well, that's fantastic. I think we need to give a massive thanks to Dr. Stefano. Thank you so much. And, a little gift to you. Thank you so much for your time. Thank you. All right. Well, it is my great pleasure now to move on to something pretty dynamic and exciting. And here she comes, swanning through the audience, the beautiful Erin Simpson, because we're about to have Breathless TV. A big round of applause for Erin, everybody.
everyone, and welcome to the next episode of Breathless TV. Coming to you live from the conference, the New Zealand Respiratory Conference for 2016.
Absolutely, it's great to be here today, and I do believe we have a few more giveaways today. I alluded to the fact that some of the giveaways are quite significant today, and we're here to chat to a few friends of ours from the conference and also have a bit of fun at the same time.
Exactly. So we still have vouchers to give away. Countdown and New World vouchers. Later on, we have $100 Resine vouchers. So right now, do you have your phone on you?
I don't have my phone on me, unfortunately. It's gone away.
Is Tiger around? We need to give away some hashtag prizes to the people who have been hashtagging. While we get that sorted, should we invite one of our guests up?
That's
Callum.
a good idea.
Callum from GSK.
Here he comes. Give him a round of applause, everybody.
Probably.
Yeah, here he is. Come on, come and sit down.
Come over here, buddy.
All right, cool.
Give you that. Callum, what have you guys been up to this year?
Well, it's been a huge year in is it on? It's been a huge year in respiratory medicine for, I'm sure everyone will agree. In March 2016, GSK launched the Ellipta portfolio of medications.
It isn't on quite yet, but we're going to turn it on because your voice is amazing.
Oh.
There you go.
Okay, I'll start again. In March 2016, GSK launched the Ellipta portfolio of medications, which are now fully funded and available for prescribing in New Zealand. We launched Brio Ellipta, which is the only one inhalation once a day inhaled corticosteroid long-acting beta agonist, which is indicated in asthma as well as COPD. We launched Incruz Ellipta, the long-acting muscarinic antagonist, as well as Anoro Ellipta, the long-acting muscarinic antagonist with the long-acting beta agonist. Together, all
Some
three...
big words there.
Big words, big
I'm holding on for my life here.
Yeah. Absolutely. Together, all three medications provide healthcare professionals the opportunity to individualise care for COPD patients, as well as having the opportunity with Brio Ellipta for asthma as well. And all delivered from this, let me get it out of my pocket,
Oh yes, demonstration time.
this intuitive Ellipta device. So, I'll do that. I'll stand up. So for those of you who haven't seen it, hold it like that. It's as easy as open, inhale, and close. Easy as that.
Oh, round of applause,
Yeah,
everybody.
come on.
Outstanding, Callum.
So what what this device offers is simple to use, simple for you to demonstrate, simply one inhalation once a day, and the opportunity to individualise your care for COPD patients.
That's awesome. Thank you so much for coming and for your time today.
No worries.
Round of applause for Callum. Now we seem to have
Oh, we've got an iPad.
brilliant.
Oh, you've got the hashtags out and about. That's awesome.
Would you like to announce the winners?
Sure. Why not?
Love putting people on the spot.
What do you reckon?
Well, there's been quite a lot of action online.
Nice.
Yes.
We'll go with Alessandra.
Alessandra posted up a picture of you actually
Oh.
at the emceeing with a lovely photo behind you. Alessandra, are you here?
Possibly. Oh, yes. Maybe
Alessandra.
that's you. That's Dr. Stefano's lovely other half.
Oh, that's awesome.
Well,
Oh, you...
thank you.
Get some free food on your holiday. What's another one we've got here? This one?
Yeah, go with that one.
Linda Gilbert at Graphic Scribe.
There she is. She's our graphic designer. How about that?
Awesome. You won. Oh,
Yes.
this one's a great one. Dr. Mariwa Glover
Did you win yesterday?
posted up a picture at Ranui Primary School winners, a picture of them dancing last night at the cocktail function.
Yes, I still think that's worthy. That's very good. Is she here today? She's speaking later on today, so she's got to be here somewhere. We'll reserve one for her as well. There you go.
Posted a selfie up of yourself.
Yeah, but okay, so I'll take the.
You don't get one. Dr. David Martino, great science today at the New Zealand Respiratory Conference 2016. #NZRC. Awesome.
There it
David.
is.
That's perfect. So we'll get
There
those
we go.
out.
Yeah.
Thank you so much for bringing that up.
Thank you. Very high prevalence of speakers posting about the conference today. But you know, later on, I did say we had bigger prizes, so I do encourage you. What is the hashtag, Erin?
NZRC.
And we'll also check Facebook next time as well. So on Facebook, the same thing works. If you've got any photos on the old FB, don't have asthma problem, a respiratory problem while you're on Facebook. Dr. Stefano told us that can happen. So just, you know, Facebook responsibly and healthily.
Now, I would like to invite Natalie up to the stage. The beautiful Natalie.
We could fill the awkward pause with the clap if you'd like. There it is.
Now, Natalie is from AstraZeneca, so welcome.
Come on up.
Now, Natalie, we're just going to give you free rein because I know you're very passionate about your job, so go
Thank you. Well, really just want to mention that Symbicort, used in the SMART regimen, is still the only single inhaler therapy for maintenance and relief for your asthma patients. That also means that it is the most effective at reducing your severe exacerbations for those patients. And as an asthmatic sufferer, I know how important it is for your asthma not to interfere with your life. So your asthmatic patients have more chance of getting on with their life when they're on this therapy. It's also simple to use and it's simple to teach. Down on the stand, we've got a whole lot of resources for you guys to be able to use if you'd like to help that conversation that you have with your patient when you're making the change to Symbicort Smart. And that also includes the Living Lung app that I believe was mentioned yesterday. I think Claire said it's revolutionised the way she talks to her patients about asthma and COPD. This is it here. Would you mind holding it?
Easy.
So if you'd like a closer demonstration, just come and see us at the stand and we'll talk you through it. It is an app that you can download, and it's a really good way for your asthma and COPD patients to understand what's going on in their lungs and why you want them to take their medication.
Awesome.
Okay.
Thank you so much for bringing that up and coming up.
No problem.
So yeah, enjoy the rest of the
Thank
day.
you. Round of applause.
Haven't we just had...
We've had a great time. We've had a fantastic time, and
We've had wonderful guests on the episode today.
absolutely we have. Now later on, we're going to do a slightly larger episode of Breathless TV, and this time, well, we've got a bit of a highlights reel coming up as well.
Yes.
So we're excited about sharing that with you, and also giving away some of our bigger prizes. Everyone say ooh! Building the anticipation for that, and anything else here, and I've completely forgotten.
It's time for morning tea, and if you're staying in the hotel, don't forget to check out of your room, and we'll see you back here very shortly.
All right, see you soon.